here for another episode of our Rational Wellness Podcast. It's confusing to know what you're supposed to do to be healthy. What should we be eating? How should we be exercising? Should we be avoiding red meat, cheese, and butter? Should we be putting butter in our coffee? How should we be exercising? Should we be taking calcium supplements, or are calcium supplements harmful? Should we take fish oil? Is fish oil harmful? My goal is to bring clarity to some of these issues using the top scientific research and interviewing experts in the field who can help us understand some of these issues. Please subscribe to the Rational Wellness Podcast on iTunes, Stitcher, or YouTube. So let's get started on your road to better health.
The hope was so enticing back in the days. Crazy new thing just finding its way, and we all couldn't wait.
Hey, Rational Wellness Podcast listeners. So happy you can join me again today. And we have a great topic on female hormones. And we're going to be speaking to a very special guest, Dr. Jill Stocker. So the topic today is hormone replacement therapy, which is the use of female hormones like estrogen and progesterone and even testosterone to help women overcome symptoms of menopause and other issues that happen as some of these hormones tend to decrease with age. And so the history of hormone replacement therapy, to give everybody a little bit of background on this topic who aren't too familiar with it, is that it was becoming more and more popular to help women with hot flashes and night sweats and vaginal atrophy and dryness and some of the other symptoms that come with peri and menopause, and as well as it was believed that hormone replacement therapy, especially the use of estrogen, would be beneficial in reducing heart disease. The general understanding was that one of the reasons why women have a lower rate of heart disease is because of estrogen, and that after menopause, as estrogen levels drop, they all of a sudden would have an increasing risk of heart disease like men have. And so it was believed that estrogen was protective. In addition, we know that estrogen can play a protective role in bone, in protecting bone density. And we always knew that there was a possible risk of estrogen-related breast cancers. And of course, there's a big debate about this, like breast cancer, endometrial cancer, uterine cancer. And then in 2002, the bomb went off, and the Women's Health Initiative study was published, and this surprised a lot of people in the field because it showed, and it was a really big study done with 160,000 women, showed that in fact estrogen didn't decrease, but there was an increased risk of heart attack, stroke, blood clots, as well as a small increase in risk in breast cancer in these women who were taking equine, estrogen, and synthetic progesterone. And so that's sort of the backdrop to the topic. Well, I should also say that today what's happened is a lot of practitioners in the field have been using what are called bioidentical hormones. And these are quite a bit different than the types of hormones that were used in this Women's Health Initiative. They're not coming from horses. They're not synthetic. They're virtually identical to the same hormones that are present in a woman's body. And so because this is a very interesting, important, and controversial field, I've asked Dr. Jill Stocker to join us today. And Dr. Stocker completed her undergraduate degree in molecular and cellular biology at the University of Arizona, and she proceeded to medical school at Kirksville College of Osteopathic Medicine in Missouri. She then completed her training and residency in Michigan, becoming board certified in family medicine. She also has advanced certification in age management medicine. And Dr. Stocker specializes in age management medicine. I think we could probably also call this anti-aging medicine, and hormonal optimization. And she has made it her life's work to help women regain their sense of self, juiciness, and vitality. Thank you for joining us, Dr. Stocker.
Thank you very much for having me, and thank you for that introduction. I love that just when you say, sense of juiciness brings a smile even to your face. So
absolutely,
I think it's something that everybody can relate to.
That's great. It's great to make healthcare a little bit fun, because it can be stressful for a lot of patients and even for practitioners sometimes.
Yes.
So, Dr. Stocker, I believe that you would agree that restoring hormone levels in most women to levels that they had when they were younger is probably a key to restoring their vitality. Is that a true characterization of the way you look at things?
Absolutely. And I want to kind of comment and speak to your introduction with regard to where hormones were, where they are now. I went through all of that. I came out of residency in 2001, and so I was taught the traditional thinking with all of the hormones. And so I went through all of that, having to take women off of their hormones and not really having much of an alternative for them other than antidepressants, which has a whole slew of side effects and issues with them. And, fortunately, we have much better data now, and we've kind of looked into those studies and what the crux of it was and what the concern of it was, to realize that there was a different solution. What you had mentioned was, people hear estrogen and they think it's horrible. They think of cancer and heart disease and everything. And the reality is there's so many different types of estrogen, and they didn't really speak to that in the media that likes to kind of blow everything out of proportion and to yank all these women off of their hormones that was giving them, a quality of life, and then just take that away from them and not offer them a solution was really difficult to go through. And so in training and learning all this information, it was really wonderful to be able to kind of give people that quality of life back, because there were different solutions. And so, like I said, one of the things that they don't mention in there is there's so many different types of estrogens. And the main one that they were studying was the Premarin and the Prempro, which is horse estrogen. And why anybody really thought giving women horse estrogen was a good idea in the first place, I don't really know. And so, but they also looked at, just plain estrogen or estradiol, and that's where they didn't necessarily give us all the information in showing that was actually a safer option that didn't necessarily cause all of these other effects. The other information that they didn't really speak to was the length of time in between starting somebody on estrogen and the events that they had was important. And so, waiting to start somebody on estrogen for 5-10 years when they may have already developed some more plaque or atherosclerosis.
So let me just stop you for a second. I just want to point out that for those of us who aren't familiar with the Women's Health Initiative study, these were women who had already gone through menopause, who were in their 60s, right? Somewhere around there.
Mm-hmm.
And then they were put on estrogen replacement, as opposed to, say, starting the hormone replacement as they're going through peri or menopause. Correct?
Exactly. And that was one of the things that they didn't explain. There is an important kind of window of opportunity to start somebody on hormones. Now, does it mean that if you are outside of that window of opportunity, then you're out of luck and you can't have hormones? No, absolutely not. There's different forms of estrogen that we can use, and the oral form tends to, if it's started a little bit later, could potentially increase any type of event. But that's why we also have different options as far as transdermal or the creams. So there's lots of different solutions now with that.
Yeah. So maybe you'd want to talk about the fact that there are different forms of estrogen, essentially three forms, correct? Estradiol,
Yes.
estrone, and estriol, and
Yes.
and there's stronger or weaker estrogens, with estradiol being the strongest and estriol being the weakest.
Absolutely. And the estradiol and the estriol tend to be E2 and E3, is another way that we call it, tend to be the quote safer estrogens that don't necessarily increase the risk for heart attack, stroke, cancers. And actually the estriol is the weakest of them, and has actually proven to be the safest. So we tend to use a combination of the two, to reduce the hot flashes, night sweats, improve overall sense of well-being, but also reduce any type of risk of heart disease, cancers, things like that.
And is there a ratio between the two that you prefer with your patients, or does it depend on the patient?
It really depends on the patient. The other thing about estrogen that's kind of tricky is, women do have varying degrees of their own estrogen that they continue to make. Perimenopause starts as early as your 30s, and most people think of perimenopause or menopause as only hot flashes and night sweats, but it really is, sleep disturbances, lack of energy, lack of motivation, losing that edge that we once had, or that sense of juiciness that we had, vaginal dryness, painful intercourse, a lot of those things, and not just the hot flashes and night sweats. So people think it's, that's just part of getting older. That's actually part of your hormones declining. And does that mean that we start estrogen right away? No, because if you're already making some estrogen and you compound that and you add a little bit too much estrogen, you can get something called estrogen dominance in a woman, and you do not want to be, you don't want to have that. So it can cause bloating and weight gain and mood swings. And so rather than just giving somebody estrogen, you can actually give a woman testosterone, which is kind of the thinking is low T is only for men, but testosterone is such a game changer for women, because the testosterone actually converts a little bit to estrogen. So you will get a little bit of that estrogen effect with the vaginal dryness and any hot flashes and things like that. So it's really important to gauge where they're at with their baseline estrogen, not necessarily just on a blood level, because or a serum level, because that can fluctuate from hour to hour, from day to day. So I really, in my practice, focus on the person that's in front of me and not the number that's on the paper. And that's how I was trained. So.
Right. Brings up a couple of questions for me. One of them is testing. But before we go into that, about a year ago, we had Dr. Nadini Verma, come and speak to our functional medicine discussion group. And she talked about the fact that she thought it was important during the beginning of peri and menopause that if there is vaginal atrophy and some bone damage, that it was potentially important that you had sort of a window where you needed to intervene. Otherwise, there might be irreversible damage. What do you think about that concern?
Irreversible damage regarding
like in terms of vaginal atrophy, and then she also thought some of the bone changes that occur, that it was potentially important to intervene initially.
Mm-hmm. Well, I think early intervention regarding hormone optimization is the key to reducing a lot of well-known diseases, diabetes, high blood pressure, metabolic syndrome, which then can lead to heart attack, stroke. So early intervention in any hormone optimization is key. So, I have women and men as early as, late 20s and early 30s that I start optimizing their hormones. And as far as, seeing irreversible vaginal atrophy, I've not seen that.
Okay.
And vaginal atrophy responds very quickly in my experience, and with a variety of techniques. Like I said, the adding the testosterone gives you a little bit of conversion to estrogen, which will then give you less vaginal atrophy. It'll help also with your lean muscle mass, which is important in preventing osteoporosis. So that's another reason testosterone is kind of a little secret that a lot of people don't know about, that women really need, that's really important to preventing a lot of different things.
Now, what about, isn't it the case that during the beginning stages of perimenopause, the hormone that's really dropping or fluctuating the most is the progesterone? What about just using progesterone, or for those of us like myself who I'm a chiropractor and practice functional medicine and don't use hormones, we try to use diet, lifestyle, and nutritional supplements. So we'll use something like chasteberry to try to stimulate the progesterone secretion.
Okay. Yeah, absolutely. Great question. I think one of the keys is to not necessarily focus on just one hormone at a time. It's about getting them all balanced, because they all work so well together to really, optimize the person's health. And I love that you mentioned, nutrition, supplements. I think all of that is wonderful. I really look at it as it's an entire approach. It's not just, I'm going to give you this hormone, it's going to fix this problem. It's all of these things. If we can, heal our gut and improve our nutrition, then we're going to absorb our nutrients and our vitamins better. We're going to absorb our own hormones better. If we can exercise to a point where we're actually, there's something called the hormonal recruitment of exercise, where you actually get to a level where you're secreting your own testosterone, your own growth hormone levels. And then the other thing that I really focus on is stress reduction and good sleep. And so it seems like common sense, and it is, but there's actually, a biochemical response to it as well. Getting good sleep, you actually are improving your own production of all of your hormones, your adrenals, you're reducing your cortisol levels, which is our stress hormone, which then, if we have too much stress or too much cortisol, then we will develop belly fat. Progesterone, which you had mentioned, is something that really helps with sleep. So by adding that, you're actually promoting optimization of all the other hormones. By giving the progesterone, you're helping somebody sleep better. You're going to boost their own production of growth hormone, which then ultimately is going to help them feel better as well.
Great. So given the fact that the goal is to optimize the levels of all these hormones, and also given the fact that, as you mentioned, some of these hormone levels like estrogen fluctuate throughout the day, what is the best way for us to test for female hormones? Is it better to use blood, urine, saliva? There's a newer method that's becoming popular, which is dried urine, the Dutch test. What is the best way that you have found to test for hormones, either before or also during supplementation?
Great question. And I've studied all of those different methods. And something that I was taught really early on in my medical training was listen to your patient. They will tell you what's wrong with them. So first and foremost, I listen to my patient, because they're going to give me more information than that one little blood test is on there. So that being said, I will comment, that's not 100% what I base my decisions on. I use serum guidelines or levels to look at, but I have seen and experienced it myself, where somebody may be perfect on paper. They may be completely normal according to the labs on paper, but they don't feel good. And I'm going to treat that person sitting right in front of me instead of that number on the paper. And that's one of the things that distinguishes me apart from traditional doctors. Is in medical school, we're taught to kind of think within the box and think within that normal range that the lab gives us. And that's just a sampling of the average population, where they're going to fall. Well, I strive for people to be optimal, where they feel best, function best, and they can do whatever they want and reduce disease. And sometimes those numbers are going to be outside of that range. So I look at serum levels as a piece of the puzzle. It's not the be all end all though.
Okay, great. Do you ever measure estrogen metabolites in urine to see how women are metabolizing their estrogen? There's controversy over this, but there's a certain amount of literature to indicate that if you metabolize estrogen along the 2 hydroxy pathway as opposed to the 4 or the 16, that there's less risk of estrogen-related cancers.
I do not, in my practice, measure metabolites. I have them have a primary care doctor that they follow up with for their routine mammograms and pap smears. And if there's any type of irregular bleeding, that's something that can happen when you initiate hormone therapy. And that's just kind of the body getting used to it. But if there's anything outside of the first month or so of adjusting things, then I have them follow up for the proper studies for that.
Okay. As far as the fact that they're to begin with, do we really know if bioidentical hormones are safer? I mean, we think they are. There's lots of reasons to think they're safer. Obviously, it's kind of crazy to think that we're putting horse estrogens into women and expecting a great result. But do we really have the studies yet to know for sure that bioidentical hormones are safer? And then if they're not, what steps do you take to reduce the woman's risk of some of the possible side effects like heart disease and breast cancer?
Mm-hmm. Great question. There's obviously a plethora of studies out there based on all of the traditional medicine. And a lot of the reason why is because of the pharmaceutical companies. They can put the money into it. With the bioidentical hormones, there still is quite a few studies out there. They're just not as well known because you can't patent a hormone. You can't patent something that comes naturally. And so it's more difficult to find information about it, but there have been no studies to show any adverse effects associated with bioidentical hormones. Now, is that to say in 10 years from now, we're going to find something out? We might, but if we lived a great life for 10 years versus being miserable, I think that's saying something too. And that's with any type of medicine too. Right. So.
How about, what thought occurs to me, maybe giving these women an advanced lipid panel after supplementing with estrogen for a while to see if it is having an effect on heart risk?
Well, optimizing all of the hormones together in conjunction with proper nutrition and exercise, which is what I teach people, really is lowering their risk overall anyway. So a lot of people, if they come to me with high blood pressure, diabetes, cholesterol, a lot of times they come off of those medicines because their profiles improve so much just by optimizing their hormones. Optimizing growth hormone and testosterone reduces percent body fat, even without proper nutrition and exercise. Not that I don't promote it. I think it's, optimizing everything, but that reduces that.
Do you ever use nutritional supplements that, for example, promote optimal excretion of estrogen and processing, like things like indole 3-carbinol, DIM, or even liver support to make sure that estrogens are, processed in a, healthiest manner and excreted from the body on a regular basis?
Mm-hmm. I use nutritional supplements. I don't use the DIM supplements.
Okay.
One that I have almost everybody on is turmeric. And it's a spice that we cook with, but it's also available in supplement form. And there's been studies to prove that it actually, they've done studies against things like Prozac and Zoloft, and it actually has more beneficial effects for mood than those do. Also reduces inflammation overall, which is what, a lot of what my program also focuses on is inflammation, which starts in the gut usually. And if you have inflammation there, then it increases your risk for plaque, heart attack, stroke.
So what form of turmeric or curcumin do you use, and would you mind letting us know what kinds of dosages you typically recommend?
Sure. I use the higher dosages. It usually, if you look over the counter, is about 500 milligrams.
Are you using turmeric or curcumin?
The curcumin
Okay.
with the black pepper in it.
With the black
Actually,
pepper.
it helps
Okay.
absorption like 1,000% better. So I use that. The brand that I particularly use is called CuraPro, and
Okay.
it's available with just one capsule per day, because I find that if you have to take 2 or 3, people aren't necessarily compliant with that. And it produces pretty immediate results with regard to inflammation. And people who have, any type of injuries, aches and pains from aging and being active, because my clients are very active, it works pretty quickly. Usually within a day or 2, they will notice a difference. And like I said, it's working in the gut to reduce the inflammation.
What
So you're
would you mind
absorbing
letting us know what brand is CuraPro, and do you know what the dosage is in one capsule?
The trade name is CuraPro, and I'm not sure the exact brand. I know that you can get it on Amazon.
Okay.
So I've seen it there.
Great. Okay. So in terms of the use of progesterone, since progesterone is, normally secreted during, part of the cycle, do you typically put women on estrogen? Let's say they're, into menopause, and their estrogen and progesterone is both low. Do you put them on estrogen and progesterone? Do you cycle in the estrogen for 2 weeks at a time, or just for a period of time? How do you typically utilize that?
Great question, because there's a few different methods that people use with that. My training and my theory is we are born with all of our hormones. We need our hormones, and they start declining as we age. And to just kind of pick and choose which ones to optimize rather than optimizing all of them is not really doing us a full service. So even if somebody, the older thinking is if you've had a hysterectomy, well, then you don't need the progesterone to balance off the effects with the estrogen. But progesterone actually really helps women feel better. We call it the feel-good hormone. Because you don't feel good when your hormones are fluctuating all of the time. And like I said earlier, progesterone really helps with sleep, which then improves all the other hormone secretions. It also helps with anxiety. So I dose it the same throughout the month. Some women, even if they are postmenopausal, or you're never really postmenopausal, you're still, having having changes. But
why is it? I have a few patients who are in their like late 70s and they're still getting hot flashes.
Well, because they're constantly declining. Your levels are constantly declining. I wish there was a reset button where we could just push a button and the next morning we just, started making them again. So, I tell people you're never going to be on the same dose for, an extended period of time, because you're changing and evolving. And also, with your nutrition and exercise, you're going to be optimizing your own hormones. So you may actually need fewer hormones if you're doing those kind of things too. So some women, even if they're not having a period, they will still feel a cycle. They'll still have like the emotional effects that they would have had, even if they're not actually having a cycle. And so for those, you're still getting that drop in the progesterone. And if those women are having those symptoms, then I will have them boost their progesterone levels during that time. So.
I can imagine that there are probably some listeners and maybe even some practitioners who have this natural argument in their head, and you've probably heard this before, but, they're thinking, look, as you age, once you're done with childbirth, you're not supposed to have the same levels of estrogen and progesterone. And, to go back and restore these levels to an earlier age is not a healthy thing to do. What would be your response to that sort of argument for?
Why not? I think you should feel as alive as possible for as long as you can.
Right.
I mean, I understand. I understand that there are people that say, I got through it without any hormones. They still don't feel very good, and they have all these medicines. I have patients that are, into their 60s and 70s, and they're going for a career change, and they just are excited about life and living life, and they're having sex at 70. And I feel like you should do that. That's great. Why do we have to be miserable?
Absolutely. Yeah. No, I'm totally with you on that, especially since I'm coming up to 60 soon. So,
yeah. And I actually did speak to a woman the other day. She said, I'm kind of old. I mean, she sounded like she was in her late 30s, early 40s. And I was surprised when she said she was 60, because I don't know really what 60 sounds like, but she said, I feel like it's too late. And I
60 is just the beginning of middle age. Yeah.
And I said, it's not too late. She said, I wish I would have been taking these or known about this earlier. And I said, you know what? Thank goodness you know about it now, because you're only 60 and you still are, on the treadmill and wanting to do this. And you do have this option. It's not too late. So
that's great. Well, thank you, Dr. Stocker. You've provided some interesting information for our listeners, both for practitioners and laypersons who are interested in health. So I thank you for joining us today. And
thank you for having me.
Absolutely. Look forward to seeing you tomorrow evening at our functional medicine meeting. And for those who would like to get a hold of you, what's the best way to get in touch with you?
You can go to my website, jillstocker.com, and it just has some basic information. I can email you directly, and also if you enter your number, I can call, and I am very hands-on. I really like to talk to people who are, if they're considering it, if they think it's an option, I can talk to them for 5-10 minutes for a free consultation to talk to them about any concerns they may have.
And is there a form on your website where
Yes.
they can make an appointment or?
No, they just enter their
Email you?
information,
Okay.
their email, and I call them directly.
Oh,
because,
okay.
like I said, I'm very
Wow.
hands-on. So,
That's great. A call from the doctor.
well,
People are
each
not
person's
used to that.
different. I like to, no, they're not. And they're like, oh, wow. That's what I love about it, though. I love being hands-on. So
That's great.
I love hearing their stories and being part of their journeys.
Excellent. Thank you, Dr. Stocker. I'll talk
Thank
to
you
you
very
tomorrow
much.
evening.
Okay.
Bye.
Bye-bye.